Hello, welcome to RxP International. I am Dr. Elaine Levine, and I have with me Dr. Elaine Foster. I'm going to present one of my cases of a bipolar patient, and Dr. Foster is going to help me in my interpretation and analysis. I like to call this case the case of the falling and rising and falling star, because Mr. Star seemed to start life in a very high point and had many failures and later successes. But of course, he came to me when he was a falling star. Mr. Star seemed to start life in a very high place. And I think you'll see that he fell and he rose a number of times. So, Dr. Foster, I would like you to kind of imagine with me what this was like one day in my office, and I would like you to imagine also a very elegant woman entering the waiting room, dressed in the most beautiful clothes, very slim. She looks around the whole waiting room and seemed to spot one corner of the couch where she would be rather to herself. She sat down very gracefully, very poised, with her hands in her lap, and said nothing. Was wondering if this might be my new client coming in. Several minutes later, a man about 6'2" burst forth from the door, very handsome, gray-haired, in a suit, polished shoes. He looks around the room and came over to the receptionist's desk, and he said, I'm Mr. Starr, and I'm here for an appointment with Dr. Levine. And the receptionist said to him, "Take a seat, Mr. Starr, and I'll be with you in a minute." And as he went to the seat next to the elegant lady, he nodded to everybody else in the waiting room and smiled. And he bowed to the elegant lady and then sat next to her, and she hardly acknowledged his presence. The receptionist came over to him and asked for his insurance card, and he handed it to her with a joke and said, I'd give you my driver's license too, but the photograph doesn't do me justice," and laughed and looked at his wife and looked at all the members in the room. And that was my introduction to Mr. and Mrs. Starr and the case of the falling and rising star. Mr. and Mrs. Starr came into my office, and Mrs. Starr made it very clear that she had had it with her husband. She said that he had to get therapy or else. He looked adoringly at her and said, "I'll get this fixed. You'll be happy with me again. You'll see. Everything will be just fine." I then began working with Mr. Starr. At the time, he was a 64-year-old, appropriate height for his weight, and he explained to me that he was referred to me by his primary care physician. He further explained that he was in quite a crisis, which of course I could see given Mrs. Starr's initial comments. But he went on to explain that his business was in foreclosure, and his wife was blaming him for all the problems of the business and had told him to get help or else. Now, the patient himself said to me, I don't really know that I need help. I think I'm all right. I feel like I'm all right. But I do think I just better get another job or my wife's going to divorce me. This was the patient's medical history. He had high blood pressure and was treated with several blood pressure medications. Even so, his blood pressure remained somewhat on the high side. As I began listening to him, he explained something about his history. He did tell me that his mother had been depressed and he thought that she had ECT at one time. He wasn't sure. And he said his father was a wonderful man, but that he'd never been real successful at work. His father had been a contractor building houses and apparently had been successful and lost his money a number of times in his life. Does that sound familiar? He also told me he had an adult son that had been diagnosed as borderline, and his relationship from his son was estranged. What I noticed very early in my work with Mr. Starr is how hard he worked to please me. It was very difficult to get him to talk about himself. He much preferred to talk about my life. He would ask me how I was feeling, and he would tell me that wasn't I tired? And of course, I would try to, as quickly as possible and politely, return the conversation to him. He often would make very charming comments when he came in about the office being attractive. Sometimes I'd even have to try to scout him down. Instead of being in the waiting room, he might be in my bookkeeper's room, entertaining her. And very often when we first came to the office, he would make some clever comment. And he once said to me, "You don't laugh at my jokes. Everybody else laughs at my jokes." And I told him that when he was better, I would laugh at his jokes too. So with that as a background, he did begin talking about himself. He described himself as a very good child. He was Catholic, went to church every weekend, and that he was an only child and did a lot of caretaking of his parents. He said he remembered that his mother was always depressed, and he would try to cheer her up whenever he could. And that he knew his father had business problems, and he would often go to work with his father and try to make sure the properties on the houses the father was selling were very neat. And he said he thinks he remembers helping his father with bookkeeping regarding his work from a very early age. Now, he was quite successful in school and accepted into a very good school and began studying medicine. And he has kind of a blurred memory that when he was a freshman, he was working full time and taking 18 hours and began to not be able to keep up with his commitments. In fact, he remembers waking up in a mental hospital one day, not a very clear memory of what happened, and being released several days later and realizing that he was failing his courses. So he transferred programs and he ended up getting a master's in business administration from this very good school. He then began to tell me more about his adult life. He said that when he was in college, actually shortly after the hospital incident, he met his first wife and she became pregnant. He was very embarrassed about that, having been raised a good Catholic, and really thought that he shouldn't have premarital sex. So he did marry her, although he wasn't sure if he loved her. And that marriage lasted 18 years. And they had the son that I mentioned to you, that as an adult himself was diagnosed with a borderline disorder and had not been fully functional. Now that marriage lasted 18 years. He said he went to marriage counseling with his first wife because she wanted the divorce. He said she was always angry at him. He really didn't know why, but eventually gave her the divorce, granted her the divorce, and gave her all the finances and money that they had in house. And he started over. Now, this very handsome, striking, charming man apparently didn't have much difficulty meeting other women, and he met his very attractive second wife, who had come in on the first session. She had inherited a great deal of wealth, and together they had started this business that just recently had folded. He had many important jobs during their marriage, and many of them took him out of town, and he would make a lot of money, but then, for one reason or another, lose the jobs. So he had these high-powered jobs, and his wife had said in the first session, with much disdain, that he got fired from all of them. Now, when I asked him about that, he said, well, the first business actually folded, and the second business, he tried to support the CEO of the company, who got fired, and he went down with the CEO. The third business, he said, he wasn't really fired, but he did feel a lot of pressure. And besides, he had another opportunity that was even better. And then he acknowledged the fourth job, yeah, I just got fired. Nevertheless, in each of these positions, he was able to make quite a good earning. And he and his wife had a very upper-class lifestyle, very wealthy friends. They traveled around the world first class. They had homes in several cities. So what do you think? What might be possible diagnoses for Mr. Starr? Well, he certainly didn't seem very happy about the divorce, so I thought there might be a mood disorder, but I wasn't sure what else might be going on. He was certainly very active. I wondered, did he have attention deficit disorder? And given their lifestyle and their high celebrations, I wondered if there could be any substance abuse involved. And I really began to suspect some disorders which we used to consider axis 2 disorders, personality disorders, and more specifically, narcissistic disorder. Have you been wondering about that also? And I certainly wondered about a bipolar disorder. Dr. Foster, have I left anything out about possible diagnoses at this point?
In terms of what I'm seeing there, I would say they are along the lines of what I'm thinking, and one of the things that I've heard talked about in the past, although not having heard how fast his speech was, or whether he tended to show other manic type symptoms, it made me wonder more along the lines like his son being borderline, and that being consistent with this idea of what's called a hyperthermic personality. Mm-hmm. Because of the ADHD, the manic and the borderline kind of tying together in this, like, doing more, always moving from job to job, and not really considering them failures, but rather maybe, reframing them in a way that doesn't call attention to his having a problem. But that's kind of what's going through my mind right now.
Okay, so at this point we really don't know. There could be a lot of different diagnoses, and we want you as students to also keep that in mind, because it's so important in terms of selecting medication that you do have a good working hypothesis about what the diagnosis might be. So clearly we need some more information. So what data would you look for to confirm your diagnosis? I think Dr. Foster's already mentioned a few. Sleep, other kinds of habits, just exactly what happened on the jobs. Let's see what else he had to tell me. As I got to know him better, he said that he had been feeling pretty sad all day for months, and he had no awareness of feeling manic in any way. He denied being suicidal, but he said he did know that he was kind of irritable and had to keep that under control. He emphasized his strong ethics to me, that he was very faithful to his wives. But I want to mention to you that that doesn't quite fit in with his description of his second wife in that first fateful meeting, when she said he was constantly flirtatious with everybody. And of course, I'd seen a little bit of that in the office in the way I had to scout him down when he was often visiting and trying to impress my bookkeeper. Now, as Dr. Foster mentioned, here's a critical factor. He only slept 4 or 5 hours a night. I've done that forever, and I'm never tired. And he did have pressured speech, and his voice was very loud. He was funny, but at times it really wasn't very appropriate humor. He denied drinking to excess, just social drinking, and actually that seemed to fit in pretty well with his strong moral upbringing. But an interesting aspect that became apparent over some time was that he came to my sessions beat up all the time. He was always having accidents. They lived on a farm now. He was a gentleman farmer. And he once fell out of a tree. And he came a second time telling me that his wife was furious with him because he was cutting weeds, and instead he cut off the rose bushes. It became clearer and clearer that he had many impulsive behaviors and many grandiose ideas. As I mentioned to you before, he was very anxious to please me, and this was an issue that we needed to discuss early on. Now, I know that all of you have different orientations. Dr. Foster was trained in a behavioral program. I was actually trained in a very humanistic program, but you've probably learned by now that I've been greatly influenced by psychodynamic thinking. And I just want to mention to you here a book or writings by a psychodynamic psychotherapist, psychiatrist, James Masterson, who talked about a closet narcissist. And what he meant by that is that, we think of the narcissist from the story of Narcissus as someone who looked into the water and fell in love with his own image. And from the psychodynamic viewpoint, you tend to see narcissistic traits in children that have either been overindulged, and so they think they're special, or have not had sufficient parenting. and have somehow learned to be a parent and be special to themselves. And I remind you now of Mr. Starr's background, where he was trying to make his mother feel good, and he was also helping his father at work, and how overly ambitious he was at work, at school, taking 18 hours the first semester, and the way he would try to please the therapist. It seemed like he, at times, was very narcissistic, but at other times showered the specialness upon the other, whether it was his wife or the therapist. Masterson describes this behavior as closet narcissism, a person that at times thinks they're special and at other times is in touch with a lack of success and failures in their life. And to deal with that, they try to resonate with somebody important, either the therapist or a wife that's very wealthy, and try to feel special by being connected to that other person. So, with this information, my working hypothesis was that he was bipolar. I especially placed emphasis upon the limited sleep, the loud talking, the kind of dramatic behavior in my office, the kind of over-sexual way he was approaching the staff and even me at times. And because of that early hospitalization, I had to wonder if maybe it was even bipolar 1, since he had been hospitalized and really didn't remember how he got there. I thought he had a lot of narcissistic traits, maybe attachment issues also, borderline traits. And I knew I needed to take into consideration his hypertension, which was only under partial control, all the personal difficulties and social difficulties in his life. So I also learned about the history of treatment. Now, he didn't know much about that early hospitalization, but he did tell me he'd been treated by several physicians. They kept putting him on SSRIs, and you know by now that those are used for treating depression. And he said they made him feel worse. Now, from the lecture you've had on bipolar disorder, you know that that could be another indication or confirmation of his bipolar disorder, that the antidepressant actually is stimulating and can make the bipolar disorder worse.
Something just that I would add to that is many times, because in the cycle of bipolarity, the longer periods are spent in depression, a clinician, even a seasoned clinician, can often miss a bipolar because they're only seeing depression. And the individual, when they're in a manic state, they aren't concerned. They're not rushing to their therapist to say, I'm manic, I can solve the problems of the world. And so you don't see them in your office during those times. And it's so easy to say, gee, the depression just isn't getting better. Let's increase the dose, and miss entirely this other phase of their existence that can be just as disconcerting to the people around them, not so much them themselves, but then also miss an opportunity to use a medication that might actually lead to stabilization of the patient.
Absolutely, Dr. Foster, and he's such a good example of that, of a bipolar patient who's, they say in the literature as a whole, they can be seen by 6 specialists before anybody ever suspects bipolar disorder. And this certainly happened to this man and had a lot to do with his being a falling star. And in fact, one psychiatrist said he did have ADHD and put him on stimulants and Strattera and Zoloft. And this is interesting. He thought he was better, but just like you said, his wife said he was much worse. Now, this is something else to keep in mind when you're working with bipolar patients. When they're in a more hypomanic or manic phase, they really are not good at assessing their own behavior. And oftentimes things are going so fast for them that they don't remember it. It's almost like their system is so on overdrive that things don't even go into long-term memory. So he had little recollection of these times, and it's often very useful, as we talk about in the psychobiosocial model, to be able to talk to significant others when you're treating bipolar patients. And here's a good example of that. She had a much different perception of him than he had of himself. Now, I want to tell you something kind of charming. As a prescribing psychologist in the United States, we have, in New Mexico, have to have extensive supervision before we can prescribe and even after we have a license to prescribe. Well, when I obtained my license to prescribe, I asked a primary care physician that I had a great deal of respect for if he would be my supervisor, because I thought I knew a lot about the psychotropics, but I really wanted more of his expertise in understanding about medical conditions. Well, this became a really charming relationship because I actually got to teach him a lot about psychotherapy and disorders, and he taught me so much about the right, careful medication management. But one of the things we had talked about early on, he thought it was really funny the first time I told him people had borderline disorders. He couldn't even imagine that was a diagnosis. It sounded so silly to him. But then also, we had talked about bipolar disorder. And my supervisor was this patient's primary care physician, and he was the first person to wonder if he might have a bipolar disorder. And I think it was because of all the interchanges we had had. So I later told him that was a very good call on his part. So before, though, the physician got him to me, he said to him, "I think maybe you have a bipolar disorder." And the patient contacted someone in another city in Chicago that he had had a business connection to. And this psychiatrist had given him Lamictal, which is one of the 3 medications that has FDA approval for bipolar disorder. That's lamotrigine. And Ativan, which is a atypical antipsychotic. And he just did this by distance. He didn't really see the patient at that time. And Mr. Starr told me that he had never felt so awful in his life as when he took that medication. It was just awful. He thought he was jumping out of his skin. He couldn't sit still. And he stopped all the medication. And he and his wife had been in marital therapy for a while. He hated that also. Remember the idea of the closet narcissist. He would try to please her in those sessions and tell her that he would do better and how much he admired her. And she would criticize him, and really nothing much was accomplished.
Elaine, I think one other thing I would comment about that is the idea that the patient does not, the typical bipolar patient does not want to take medication for their manic symptoms. And really, who can blame them? If you're feeling great, if you think that you can conquer the world, If you think you can start a new business venture and staying up at night is going to only enhance your ability to be more productive, why would you take a medication that slows you down, that feels like it's going to interfere with your thinking, your clarity of thought? Because in your mind, your thinking is very clear. Even though the people around you may say, wow, you really believe that? That, you can make this company in one day, or whatever it may be. But the idea is, I just wanted to call attention to the fact that um, treating this population with medications is probably one of the hardest things you can do because of the fact that they feel so good. And why would you want to medicate that?
And then you add to that they don't, when they're feeling so good, they don't see how they're affecting others. And
Yes.
and then there's also the facet that while they're on the way up to getting really, really manic, they're often so charming, clever, wonderful, and they bring many people in. And this happened over and over again with Mr. Starr. People would think that he was a star, and he would bring them in, and then he would get a little bit too manic and didn't make sense, and they would pull away from him. So it was an up and down life for him, for sure.
And you can imagine how upsetting that can be, to feel like people are with you and you're running as a pack in pursuit of this wonderful goal, and all of a sudden it just kind of reaches this threshold where now they're pulling away from you and you're suddenly left alone.
And everybody's mad at you. And he was smart and sensitive enough to know that. And that's where I think this narcissism got so curious, that sometimes he was grandiose and sometimes he felt bad. And so the way he felt grandiose was this kind of mirroring significant people. So because he was aware, very aware, that people were furious with him. They either loved him or they were furious with him, but he couldn't figure out his behavior that contributed to that. So let me ask you, and then I know that Dr. Foster knows the answers. Why do you think he felt so terrible on the stimulant? And then, remember he said he just felt worse and got really more anxious? And then, what do you think happened when he got on, that psychiatrist put him on the Lamictal and the Geodon, and he said he was jumping out of his skin and weirder than he'd ever felt? What do you think, Dr. Foster?
Was he on the stimulant and Lamictal and Geodon all at the same
No.
time?
Oh, see, there were early doctors, physicians, that thought he was depressed, and they kept putting him on stimulants. And he kept saying, no, that didn't work. I felt terrible. So we know
he's on Lamictal and Geodon and saying that he feels like it's making him
stir crazy. Okay. Absolutely stir crazy. So first, doctors are putting him on serotonin reuptake inhibitors, thinking he's just depressed. And that's not good because
we know that when a bipolar patient is put on an antidepressant, there is a greater likelihood of what's called a switch from depression to mania.
Perfect. Now, so later, my primary care doctor, who learned about bipolar disorder, said, maybe you're bipolar. And he contacts this psychiatrist that he knows in Chicago that puts him on Lamictal and Geodon. So it's not a stimulant, it's not an antidepressant. But he says now he's jittering in a different way, and he's just jumping out of his skin. He's never felt so horrible in all of his life. What do you think that is, Dr. Foster?
Well, with the Ziprasidone or Geodon, that would be the first agent that I would consider when he describes that, because we know that the atypical antipsychotics are more likely to cause akathisia, and that is that sense of internal restlessness that makes most patients decide, I'm not taking this medication anymore.
No, right. I mean, you're right. And he stopped. And just like Dr. Foster has taught you in one of our earlier courses on psychosis, the psychiatrist stopped his medication and put him on Ativan. This is one of the ways you said you could help deal with akathisia. But the problem is he didn't explain anything to him about these difficulties. He just stopped it. So at this point, I tried to explain to him something about why I thought, what I thought his diagnosis was, bipolar, and how the SSRIs can affect bipolar patients, and also about how I thought the Ativan had caused akathisia. And we worked pretty hard on how he was relating to me and his wives. And just what you talked about, Dr. Foster, it was a lot of work. He didn't want to accept that he had a disorder. He knew he had problems, but he was very ashamed about having a disorder. So it took a lot of work to build around that and talk about how it's treatable and how it didn't have anything to do with how competent he was, and a lot of supportive therapy, which is something all of you can do for people like this. Now, we said there's 3 medications that have Food and Drug Administration for treating bipolar disorder. He'd already been on Lamictal, lamotrigine. I certainly didn't want to try lithium right off because it has such a high side effect profile that you have to watch for and constant testing. So the third was Depakote. I made a decision that we would try him on Depakote. Now, Depakote requires some pretty frequent monitoring too, because it can affect the liver. We've talked liver functioning. We've talked in great detail about how these medications can be so helpful, but they all have side effects. So it was important to begin doing these blood tests frequently. And the Depakote was very helpful to the client. He began feeling better and allowed us to be more effective in the therapy. I could teach him much more about bipolar disorder. He was gaining insight about how that may have contributed to the ups and downs in his life.
Before you go on, you said you made a decision about putting him on Depakote. Were you collaborating with him to come to that decision, or
yes,
did you just feel like he was not?
We discussed the possibilities. He wouldn't consider lamotrigine at this point, because remember when he had been on lamotrigine in Ativan, he'd had this horrible reaction. This is early on, and I told him I thought it was the Ativan that caused that. But in his mind, the two were together. So he wouldn't consider that. That would have taken less monitoring and has side effects, but I thought would be easier for us to manage. And we talked about the lithium and the Depakote and decided on the Depakote. He became quieter, more reflective. He would tell me that his wife thought he was doing quite a bit better. He didn't come in with so many bumps and bruises, and that was a good thing. We were maintaining his Depakote at a therapeutic level, But you know, now we have, just like Dr. Foster warned us, he's not manic, and he became more and more depressed about the loss of his business. It's almost like his reality testing was better, and really concerned that his marriage wouldn't last. So what would you do next? Well, he was so distressed about the situation with the business and getting so agitated that I decided, with collaborating with him, to give him a benzodiazepine to help when he just couldn't handle the stress now that he was thinking about how big the problems were. And that seemed to help him to stay calm without feeling like he needed to be manic again, so that we could address these other issues in therapy. I thought maybe we were home free, so to speak, and it was only going to get better from then on, because he said he was feeling better now. His wife said he was doing better. He even said to me, he was becoming so much more insightful. Nobody's gotten mad at me recently. And so that was a relief to him. But he was so sad about the marriage falling apart. And his liver profile was elevated.
Uh-oh.
Uh-oh. So I consulted with the PCP. He didn't think, that's his primary care physician, he wasn't fully alarmed about the liver profile being elevated, but he's a very good physician, and he wanted us to check on it every 2 weeks. He didn't want it to get any higher. And so that's what we did, and we continued working under those conditions. And the patient still was progressing, but the liver function tests remained elevated. And the patient became concerned about the cost of these blood tests. New variable.
The other thing I like the fact that you brought this up, because one of the potential side effects of using Depakote is hepatotoxicity. And so it's just a nice way to remember that.
Right. Everything that could happen happened with this man. Okay, fortunately, by this time, I had a relationship with him. And so now when I said to him, you know that bad reaction you had to Geodon and Lamictal? It was the Geodon, not the Lamictal, that did that. I'm really quite certain. And would you consider a second trial on the lamotrigine or the Lamictal? And see, this is the importance of having that relationship, because at this point, he wasn't doing it just to please me, because he really thought about it. But he said, if we go up on it gradually and you really think that's the best, I'm willing to give it a try. So that's what we did. We increased it very gradually. It worked very well for him, very well. And he obtained a new high-level position out of town as a management consultant. His wife was still being very harsh with him, and I mean harsh. He came into a session once, and she had said to him, you can stay with me as my ward. Can you imagine? As my ward. And you know something else that she told him? And this, I think, goes back to his earlier time when he was more impulsive. She felt that he was messy when he urinated in the bathroom, so he went outside of the house to urinate. And he was willing to do that to keep her happy. So we still have this secondary narcissistic, closet narcissistic trait that we're dealing with. And even though she said he was a ward and he went to the bathroom outside, he was still staying with her when he wasn't away at work. And now he's making quite a big salary again. So this went on for quite a while. He came in for bi-monthly positions. He started discussing this job. He moved up the system really fast in this business, as he always did, even though he wasn't manic at this point. He did have a lot of skills, and he was very dashing. But he wasn't really comfortable. He ethically didn't like some of the things happening in this job. So, we're not terminating yet. He decided to quit his job, and he came in and told me that he had been divorced for 6 months. Now, I'd been seeing him during this time, every other month, hadn't told me. He was really ashamed about it, still living up with his wife, still had his wedding ring on, and now he was really profoundly depressed, really depressed. What to do? What would you do? Do you have any thoughts, Dr. Foster? Remember what you said earlier. He'd never been on, this may not influence you, but he'd never been on a medication for his bipolar disorder and an antidepressant at the same time. He'd been on either an antidepressant or that lamotrigine and Ativan. So just as a hint, that certainly influenced my thinking.
Well, him looking as sad and flat, of course, the consideration would be, should an antidepressant be introduced in this case? The other thing that I would wonder about is, how is he using the benzodiazepine that you're giving him? Because we know that that can have CNS depressant effects. And if he tends to drink in order to medicate any of his symptoms, it's also possible that that could contribute. So I'd want to ask about those kinds of issues. But if it turns out that it's not due to him maybe increasing his drinking or use of the benzodiazepines in conjunction with these very difficult to handle life events, his wife divorcing, I'm assuming she divorced him, and him feeling like he doesn't have a job, he doesn't have a wife.
And he's a ward.
And he's
a ward in her custody.
Yeah, the idea that there's kind of this confluence of psychosocial factors in addition to maybe some biological ones going on, you really would have to consider those before making any decision about how to proceed.
Well, I wasn't giving him enough Ativan, benzo, for him to be relying upon it too much. I think it was a 0.5 Ativan, and I think I gave him maybe 15 for the month. So I thought, well, now that he's on a mood stabilizer, maybe we could try a little of an antidepressant. I'll give him one that helps with the anxiety. And I tried, that wasn't in isolation. I did also what you said. We've got to give him some hope. We've got to do something around the therapy. At this point, he's getting close to 68 years old, I think. And so I tried to change the focus. And, it says he's 64. I'm sorry. So he was 64, but he's kind of getting up there. And I tried to change the focus, and I said, maybe you don't want maybe you shouldn't try to just be successful one more time. Is there anything else in your life that you haven't achieved? Why don't we switch would you consider another life goal from being so a big businessman. And we kind of focused on the idea that he'd never had a close, meaningful relationship with a woman where he felt supported and loved. It had always been this kind of where he was trying to impress them relationship by making a lot of money and doing everything they want and pleasing them. And he liked that idea, so we decided we would work in that direction. Well, look what happened. The SSRI still didn't work, even with the mood stabilizer. He felt worse. Now, what was really good about this is in the past, I would have had the hardest time finding out that the medication didn't work because he wanted to please me. And he would always kind of work around it and say, well, you know, I know you made a good decision, but maybe I shouldn't take it so often. This time, he was able to come in and said, wow, that didn't work. I felt worse. So we stopped the antidepressant and just focused on the relationship building. At this point, he got on a line on one of these dating services. Well, as I've described him to you, I'm sure you're not surprised that it was no time at all, and he found a beautiful woman on Match.com. Interestingly, she wasn't rich. She was a school teacher, so that in and of itself was rather dramatically different. And we worked very hard in the sessions about relationship building. He had this tendency to do the same kind of patterning with her. He initially wasn't really being very authentic, trying somehow to please and impress. So we moved from medication and diagnosis as a concern to relationship building. And he got a part-time position at a university art gallery, which was very enjoyable. So at this point, the patient was much happier. He began sharing events in his life with his new relationship and bringing friends in. And one of the striking factors was that he was so much more aware of himself. He would come in with a little notebook, and rather than trying to impress me or be clever, he'd take notes about what he wanted to work on. This is what we mean when we say being not only medically minded, but also more psychologically minded. So I continue to see this patient now in a kind of ongoing termination phase. In this phase, I monitor his medication every few months, and he reports on events and how he thinks he's doing. We discuss whether or not he feels that he has enough control over his impulses that he could function without the medication, and he doesn't think so yet. We always look at what would tell him the problems are getting worse and that he needs to come in more often, such as not sleeping well. And for him, if he starts having too many accidents, or if his wife gets frustrated with him, but he's maintaining well. In fact, several days before this case study that I'm presenting to you, I opened up the local newspaper and found his photograph in the newspaper. There's someone in town that was photographing senior citizens that were doing well. And as this handsome, charming man, they had picked him out. And what he had to say about himself is that he didn't feel like a senior citizen, that he had such a happy life and the best relationship of his life. So this is the case study, but can you see how it does follow aspects of the psychobiosocial model of care, you can see how important the relationship building was, and using that time to make a careful diagnosis, even recognizing that the diagnosis or the medication management might change in later stages of the therapy. And you can see too with this patient that in the active working stage, there were levels of psychotherapeutic encounter that were necessary in different goal setting. I think this is probably true for all patients, but especially true with bipolar patients because they become so different once the manic behavior is more under control. And I think this is the case too that shows you that termination may not mean a permanent end to treatment in the short run, but effectively means staying in touch with the patient over the long term, hoping that eventually their psychological skills and understanding are sufficient that they can function with very limited or perhaps no medication. So this is the case of my falling and rising star. Dr. Foster, thank you so much for your astuteful comments during this, and I particularly like them because they agreed with mine. And we hope this was a helpful case for you in understanding bipolar disorder.